Hi, gang. We're going to talk about something that a lot of people enjoy in an abnormal site. During this lecture, we're going to actually talk about dissociative identity disorders, which has previously been called multiple personalities. Also, we're going to be talking about what's called somatic disorders and other dissociative disorders. Now, there are several types of somatic disorders, and we have one that's called illness anxiety disorder. We got another that's called somatic symptom disorder, conversion disorder, factitious disorder, and then psychological factors affecting mental conditions. Soma actually means body, and somatic disorders, they have a preoccupation with the health, the body appearance, or the functioning of the body. But the difference is there's actually no identifiable medical condition that's causing the physical complaints. The clinical description, there has to be a presence of one or more medically unexplained symptoms. There has to be substantial impairment in social or occupational functioning. There has to be concern, significant concern, about the symptoms, and in severe cases, the symptoms actually become the person's identity. It's a relatively rare condition. The onset usually occurs in adolescence. It's mostly likely to affect unmarried, low socioeconomic women, and it does run a chronic course. Features of the somatic symptom disorder include one or more of the somatic symptoms that are distressing or result in significant disruption of daily life, excessive thoughts, feelings, and behaviors related to the somatic symptoms and health concerns, as manifested by at least one of the following: a disproportionate and persistent thought about seriousness of symptoms, a high level of health-related anxiety, and excessive time and energy devoted to symptoms and health concerns. Although any one symptom may not be continuously present, the state of being symptomatic is persistent, and it's usually more than 6 months. Now, somatic symptom disorder with predominant pain. Here, the person has some kind of somatic symptom, and this was previously called pain disorder. They are clearly in physical pain, but it cannot be explained medically. Little is known about the origin, and it affects about 5 to 8% of the population who has this disorder. Causal factors, well, again, little is known. We do know that it may include family history of this illness. It can be influenced by stressful life events, and it may include sensitivity to physical sensations. The experience suggests that there may be benefits to illness, such as gaining attention. All right, the way they treat it, cognitive behavioral therapy is the best treatment. Again, these disorders don't respond well to medication. You want to reduce the tendency to visit numerous medical specialists. These people doctor shop. You need to assign one physician that's going to take care of the individual instead of having them meet with 4 or 5 without the doctors communicating with each other. You want to reduce supportive consequences of talking or noticing these physical symptoms. Features of illness anxiety disorder These include the following: they're preoccupied with fears of having or acquiring a serious illness. Their somatic symptoms are not present, or if they are present, they're very mild. If another medical condition is present, there will be a high risk of developing one. The preoccupation is clearly excessive or disproportionate, and there will be a high level of anxiety about health. The individual performs excessive health-related behaviors such as repeatedly checking his or her body for signs of illness, for exhibiting maladaptive avoidance. These people may actually avoid doctor's appointments. Illness preoccupation has been present for at least 6 months, but the specific illness that is feared can change. The clinical description of illness anxiety disorder: physical complaints without a clear cause, severe anxiety without the possibility, or severe anxiety about the possibility of having a serious disease. Strong disease conviction and medical reassurance does not help these people. Okay? It's very similar, actually, to hypochondriasis. Statistics. Its prevalence is estimated between 1 and 5%. Its onset is at any age. The sex ratio will be equal. It runs a chronic course. Culturally, these orders are similar to illness, culturally specific disorders similar to illness anxiety disorder are such as Coro, Dat, and Keol, and I can't pronounce that. Illness anxiety disorder causes. Well, actually it can be caused by a cognitive perceptual distortion, a family history of illness, treatment. You have to challenge their illness-related misinterpretations. You have to provide more substantial and sensitive reassurance, and you have to educate them about the illness. You have to put them through stress management and coping strategies. Again, cognitive behavioral therapy is generally effective and one of the therapies of choice. Antidepressants may help, but they're not going to cure it or really affect the illness or the course. Clinical description: physical malfunctioning of sensory or motor functioning, such as, and we're talking about conversion disorder now. This is where somebody is going to have something happen, like all of a sudden becoming paralyzed in an arm or a leg. They may develop blindness for no reason. They might have difficulty speaking for no known reason, and we can't find an organic explanation. They retain most normal functions, but they will lack awareness on this. Features of conversion disorder: they include one or more symptoms of altered voluntary motor or sensory function. The evidence of incompatibility between the symptom and recognized neurological or medical conditions will be present. The symptom or deficit causes clinically significant distress. It can cause impairment in social, occupational, or other important areas of function or warrants medical evaluation. One of the things that we look at when we start diagnosing disorders: is it affecting a person's day-to-day functioning? Is it affecting their day-to-day lifestyle? Conversion disorder is actually very rare. It has chronic intermittent course. It's often comorbid with anxiety and mood disorders. It's primarily a female disorder. Its onset is usually in adolescence, and it's common in some cultural and religious groups. Conversion disorder is what Dr. Breuer dealt with Anna O about. The very famous Anna O case. Conversion disorder is not well understood. The Freudian psychodynamic view is that past trauma or unconscious conflict is converted into a more acceptable manifestation, such as physical symptoms. Primary, secondary gains. Freud thought the primary gain was the escape from dealing with the conflict, but then the secondary gains, attention, sympathy. Conversion disorder, treatment, very much like some somatic symptom disorder. If the onset is after a trauma, they may need to process the trauma. They may need to go through post-traumatic stress disorder evaluation and or treatment. You need to remove the sources of the secondary gain, and you need to reduce supportive consequences of this disorder. Factitious disorder. This is where somebody purposely fakes an illness. They may actually induce physical symptoms or just pretend to have them. There will be no obvious external gains. This is not malingering. Malingering is where physical symptoms are faked for the purpose of achieving a concrete objective, okay? This, they are faking, but there's no external gains. The feature of factitious disorder include falsification of physical or psychological signs, symptoms, induction of injury or disease in oneself or somebody else. It's associated with identified deception. The individual presents himself or herself to others as ill, impaired, injured, or presents another individual in this way. The deceptive behavior is evident even in the absence of obvious rewards. Factitious disorder imposed on another. Now this is called Munchausen by proxy. The new name is factitious disorder imposed on another. We used to call it Munchausen by proxy. Here, you cause another person to be ill or to have some kind of medical problem. Typically, the caregiver will induce the symptoms in a dependent, such as a child. The purpose? They get a lot of attention and sympathy. You know, what a wonderful parent they are for staying with the child 24/7 at the hospital, or look how dedicated this mom has been, when actually she's the one that's making the child sick. Okay, psychological factors affecting medical condition. Diagnostic label is useful for clinicians. It indicates that psychological variables may be impacting a person. Examples: chronic anxiety attacks, worsening asthma, or needle phobia, making it impossible to get important blood work done. Now let's talk about dissociative disorders. Dissociative disorders used to be called multiple personality disorder. Now, first of all, this is not the same as schizophrenia. Many people will confuse schizophrenia with DID. It is the defining feature of a dissociative identity disorder is where a person will have actually two or more different personalities residing inside of them, within themselves. They will have as many as 100 new identities. They may just have 2 or 3, but the average is 15. These people will actually display unique behaviors, voice, postures, They can display different genders, different ages. It's amazing how these people can change in compliance with what their personality presents. Now, their different personalities are called alters. These are the different identities or personalities. Now, the host is the person that actually keeps the other identities together. They're the ones that's kind of the one that presents to the others, and to the world. And the switch is where a person has a transition from one personality to another. The ratio of females to males is high, so it's predominantly a female disorder. It's about 9-to-1 on the ratio from females to males. The onset is almost always in childhood or adolescence, normally due to a severe childhood trauma. High comorbidity rates and lifelong chronic course also is associated with this, and it is more common than we previously thought. Now it's about 3 to 6%. We actually used to think that it was much lower. Features of dissociative identity disorder include disruption of identity characterized by 2 or more distinct personality states. The disruption or marked discontinuity in sense of self and sense of agency, accompanied by related alterations in affect, behavior, consciousness, memory, perception, cognition, and sensory motor functioning. Recurrent gaps in the recall of everyday events, important personal information, and or traumatic events that are inconsistent with ordinary forgetting. The symptoms will cause clinical distress, and it can cause a problem in day-to-day living or adult daily living skills. The disturbance is not a normal part of broadly accepted cultural or religious practice. It is not attributable to the physiological effects of a substance or another medical condition. Now, a lot of the times when the doctor, and this is kind of hard to diagnose, but many times doctors will start asking questions like, do you find articles that appear at your house or within your possession that you don't remember buying? Are people identifying you by another name when you're out in public and you don't know them, but they act like they know you? Do they have examples of handwriting that are different, that they both that the person supposedly wrote, but the handwriting is different? Are they suffering headaches? Are they complaining about a loss of time, not knowing exactly what happened during this loss of time? Are they being accused of going places or being places that they don't remember? All these things are very closely related or part of dissociative identity disorder. It's typically linked to a history of severe chronic trauma, often abuse in childhood. It's closely related to PTSD. It actually might be an extreme subtype. The mechanism to escape from the impact of trauma might be a cause of DID, and there are possibilities that there's a biological vulnerability possible. Treatment? Well, the therapist has to try and focus on reintegrating the identities. You have to try and identify and neutralize the cues and triggers that will provoke the memories of trauma and dissociation. And you may have to try and have the patient relive and confront the early trauma. Sometimes this is achieved through hypnosis. problem because do you have a person that has false memories, or is there really something that they have repressed or that they are remembering that happened a long time ago that was very traumatic to them? False memories can be created innocently, or they can actually be created through things like comments that a therapist might make. It's fairly easy to create false memories through suggestibility. By studying repressed memories, they have decided that there are some patients thinking that they have repressed memories of abuse, which later are shown to be false, but they have caused damage to other people and their own families, such as somebody who remembers seeing their father kill somebody and then reporting this to the police. The father is arrested and tried. Then she finds out that this was actually a memory that was induced by the therapist through hypnosis. And the father, who has now gone to prison, they have to try and find a way to get him out. Therapists need to be well trained in memory function. They have to make sure that they're trained not to plant these memories even by accident, and not to suggest an untrue history by mistake. Okay. So, there are other dissociative disorders. Now, all of these dissociative disorders, they're going to involve a detachment from reality. It can actually be a severe alteration, but this detachment from reality is kind of going to a safe place in their mind. A lot of times, like somebody might have endured a tremendous amount of abuse, and they couldn't get away physically, so they found a safe place in their mind, and while they were enduring the physical abuse, they survived by going to this place in their mind. And now sometimes they will go there and it won't be voluntarily. Depersonalization is distortion in perception of one's own body or experience, kind of like feeling like your body isn't real. And derealization is losing a sense of the external world, such as like you're feeling like you're living in a dream. The DSM-5 has 4 types of dissociative disorders: depersonalization, derealization disorder, dissociative amnesia, and dissociative trance disorder. Depersonalization, derealization disorder, it's recurrent episodes in which a person has sensations of unreality in one's own body or surroundings. Their feelings will dominate and interfere with life functioning, and they are only diagnosed if the primary problem involves depersonalization, derealization. Similar symptoms may occur in the context of other disorders, such as panic disorder or PTSD, so those will have to be ruled out. There is a high comorbidity with anxiety and mood disorders. 1 to 2% of the population will have depersonalization, derealization disorder. The onset is typically in adolescence. It will usually run a lifelong course, and it will usually take a history of trauma that will make this disorder more likely to present itself or to manifest. Features of depersonalization and derealization disorder, they include the following: persistent or recurrent experiences of depersonalization, derealization, or both. During the depersonalization or derealization experience, reality testing will remain intact. The symptoms will cause clinical significant distress or impairment in social, occupational, or other important areas of functioning. The disturbance is not attributable to the physiological effects of a substance or other medication or other physical condition. Risk factors: cognitive deficits in attention, short-term memory, spatial reasoning, deficits related to tunnel vision and mind emptiness. Such persons are very easily distracted. Little is known how to treat it due to limited research. Dissociative amnesia. This is where a person, they are going to forget a part of their life, okay? They may forget who they are. They may forget different elements of their life. There's also a part that's called dissociative fugue. This is what, during an amnesic experience, somebody will start traveling or wandering, sometimes assuming a new identity in a different place. They will be unable to remember how or why they've ended up in a new place. I actually had one case of this, and the lady came to me, and in a year's time, she had been diagnosed with breast cancer. Her husband died with liver cancer. She had, I think, one, if not both of her parents had died. She retired, and there seemed like something else. Well, any of those are major stressors. Well, for Thanksgiving, she had 9 siblings, and they called her and they said they thought that with everything that had happened to the family, they all needed to get together for Thanksgiving. She was the centrally located sibling, so they were all going to come from these other states and converge on her for Thanksgiving. They said, we'll send you money, you can go out and you can get the food, whatever you need to do, and then when we get there, we'll help you to prepare, not prepare, but to try and get things set up and help you as well as we can. Well, so here she has like 18 adults converging on her with children. She has to be responsible for taking care of all this. And after it was all over, and after she washed the last dish, all of a sudden she put away the dish towel, picked up the phone, told her daughter not to worry, everything was going to be okay. And 3 days later, she actually regained, I would say, consciousness. I mean, she regained the ability to be aware that she was not anywhere that she knew at all. And so she found out that she had gotten in the car, gone to the ATM, withdrawn $3,000 out of her bank account, driven to Texas, and she was staying in a hotel, and 3 days later she all of a sudden realized that she was not where she normally was. Took her a little while to find out where she was. She called a friend. The friend helped her to get home, and then the friend, who was one of my clients, suggested she see me. And after we talked a little bit, I just basically said that her brain was exhausted and decided to take a vacation whether she wanted to or not. She never had another case of it. She recovered very well. She adapted, and like I said, she recovered very well, and last time I heard, she was taking cruises and enjoying life. Dissociative amnesia is an inability to recall important autobiographical information, usually of a traumatic or stressful nature, that is inconsistent with ordinary forgetting. The symptoms will cause clinically significant distress or impairment. This will be in social, occupational, or other important areas of functioning. That means it's going to cause problems in their day-to-day living, day-to-day functioning. The disturbance is not attributable to physiological effects of a substance such as alcohol or drug abuse, a neurological or medical condition, or any other psychological disorder. It usually will begin in adulthood. It will be rapid in onset and rapid in dissipation. Little is known about the cause, but trauma and stress can be a trigger. Most will get better without treatment. Most will remember what they have forgotten. Dissociative trance disorder. Here, symptoms will resemble other dissociative disorders. The dissociative symptoms and sudden changes in personality will occur. Changes will often be attributed to possession by a spirit, like a demon. Presentation will vary across cultures, and it's only considered disorder if it leads to distress or impairment. It's often attributable to a life stressor or trauma. Little is known about the treatment. You may have to address the trigger, the stressor, or the trauma that led to it. All right, that is the end of the dissociative and the somatic disorders, and I hope that it helped you.